So my name is Michelle Hughes. I am an FASD coordinator with Sunbeam Developmental Resource Center based out of Kitchener. We serve Waterloo Region and the townships. And I have been immersed in the FASD community for quite a long time. My son does live with an FASD and was diagnosed close to 10 years ago, which is where I met Karen while I was seeking supports and the diagnostic journey and how complicated it is. We've come a long way since then. Prior to this, I was executive director of a not-for-profit in the region and spent a lot of my career in the field of seniors and community development. So I was one of the founding co-facilitators of the Waterloo Region Parents FASD Parenting Caregiver Support Group. And I used to participate with Karen in a lot of these types of trainings and presentations talking about the lived experience. I recently became a published author sharing that experience of the journey of parenting a child living with exceptionalities, special needs, or FASD, whatever we all kind of share together. And I'm just really passionate about building FASD-informed communities, which makes these presentations so incredibly important so that we're all aware that FASD is all around us and how we can make it more inclusive for those living with and caring for those with FASD.
All right, so then there's me, and I think there might be some people not on mute. So if you want to just check that you're on mute, that would be great. So I'm Karen Huber, and I am an FASD coordinator at Sunbeam. Previously worked in children's mental health at Lutherwood for over 20 years. I co-chair the Provincial FASD Worker Community of Practice. There are about 54 of us across the province that help support kids and families living with FASD, and we'll let you know how to connect with that person in your community at the end of the presentation if that's something you wish to do. I am on FASD 1, which is the FASD Ontario Network of Expertise, and help them with their vision around building diagnostic capacity in the province. And I also sit on the Health Nexus Advisory Committee, and they have the provincial funding for a website and for caregiver support grants. And I also do a little bit of this in private practice, and I'm always continuing to learn as more and more FASD information comes out over time.
As we do our presentation, before we begin, we have a few acknowledgements that we like to share with our audience. One is that understanding FASD as a societal issue is fundamental to this presentation, and as such, we lay out these key understandings before we begin. We acknowledge the experience of pregnant persons and strive to be inclusive of everyone. The language we use in this presentation may include women, woman, mother, and person. And culturally competent services and supports include thinking of how specific groups of individuals may view the use of alcohol and pregnancy both individually and combined. This is our favorite slide, well, my favorite slide, I should say, and we incorporate it into everything that we do because I think it's really important. When we're looking at, if you're a service coordinator, if you are a parent or caregiver, if you will see, if you're a teacher, if you're a clinician, you will see that FASD is very intersectional. And so this slide clearly details that FASD is a global health issue, a disability rights issue, a women's health issue, a food security issue, a housing issue, a criminal justice issue, and a mental health issue. And you cannot solve or serve one without serving the other. And in a lot of the presentations Karen and I do outside of this one, we talk about the social determinants of health for women, children, and individuals, and how when you're doing FASD work, and I'm sure many of you understand when you're supporting those living with mental health, that these are also intersectional. So FASD is fetal alcohol spectrum disorder. It's a diagnostic term used to describe the impacts on the brain and body of individuals prenatally exposed to alcohol during pregnancy. Some people do say FAS, fetal alcohol syndrome. We're not going to smack anybody's hands or anything and wave our finger at you, but the proper diagnostic term is fetal alcohol spectrum disorder. And it is a lifelong disability, and individuals with FASD may experience challenges in their daily living and need support with motor skills, physical health, learning, memory, attention, emotional regulation, and social skills. Each individual with FASD is unique and has areas of both strengths and challenges. So recognizing that on any given day, age, or stage, All of those details that need support may happen all at once or in different ways, but every person with FASD is unique, and all of those areas of challenge must be assessed, addressed, and identified. Prevalence of FASD tends to be something that can be a bit of a shocker to those who are not familiar with FASD. But CanFASD, which is where we get our evidence-based information on FASD in Canada, there's a lot of collaboration happening with academia, research, and lived experience with CanFASD, and their research suggests 4% of the population, and that study was done in 2017. Our most recent US-based population study came out and said that it's 7% of the population. What we'll learn a bit about tonight, and what we talk about often when Karen and I are out doing our work, is that these numbers are people who are diagnosed with an FASD. But we know that FASD is disproportionately misdiagnosed and underdiagnosed and not identified. We do also know, based on the same study by Popova as well in 2019, that rates of FASD are 10 to 40% higher than the overall prevalence rates in special education settings, correctional facilities, children in care, Indigenous populations, and specialized clinical settings. And these are places where we do see a lot of individuals diagnosed with mental health diagnosis as well. So we're hoping to clear some of that and just kind of give some differentiating information for you tonight. So we cannot talk about FASD at all without addressing stigma. And a large portion of the reason that FASD is not as openly discussed or shared or supported has a lot to do with stigma. And we see stigma all across the FASD spectrum, for biological mothers and pregnant persons. We see the stigma for those living with an FASD, those who care and support those living with an FASD, and overall society stigma towards alcohol. So what we always say to people is, we want you to be honest, think to yourself. This is not a share with the group question, but what are your first thoughts or impressions of FASD? And if you are informed, that's great. And if you're just learning, it's okay to think the thoughts you're thinking. And if you are well-versed, think of when you first started to learn about FASD. What were your thoughts and impressions of FASD? Who were you thinking of? What did you picture? Who is that person that has prenatally exposed pregnancy? And what Karen and I want to do is stamp out that stigma, because it really isn't true. It's the media and images and false information and the grief and loss that comes along with FASD that perpetuates stigma. So again, Karen pulled a bunch of these ads. You can see it seems like it's very simple, right? So it's a woman drinking alcohol, a woman's hand over a drink, and a baby in a bottle. It is not that simple, and all of this imagery leads to say that it is a woman's fault, it is a woman's problem, and the onus is on the woman to just not drink, which we know is not that simple. Next slide, please, Karen. So we have to stamp out stigma for birth mothers and pregnant persons. And how do we do that? Somebody got off mute there, okay. That we understand wholeheartedly that no woman or person that is trying to get pregnant drinks intentionally to harm their child. That does not happen. We know that so many women are unaware that they are pregnant. Depending on your age demographic and the social circles you're in, or maybe you have children that are in the stage of life where they're planning pregnancy, we are bombarded with those images on social media, on TV, of people trying to conceive and having that wonderful moment where they're looking at the pregnancy test and find out they're pregnant. When in actuality, 60% of pregnancies are unplanned, which means there's a lot of individuals who have no idea that they are pregnant and may be consuming alcohol. So many people are poorly informed on the dangers of alcohol during pregnancy. I often tell the story that I was at a baby shower 3 years ago. Someone that I've known for many years, as an acquaintance, not someone I'm exceptionally close to. We were just having a conversation. Somebody was talking about smoking cigarettes during pregnancy. I'm like, I don't know anything about that. I said, I just, it only hard for me when individuals drink during pregnancy. And this woman stood up and said, oh, to heck with that. She's like, my doctor told me once a month I can have a beer. So I wait to the first of the month and I have a beer. And everybody looked at me and expected me to get upset or angry. And I literally didn't say a word. And when I was asked after, I said, well, if your doctor tells you it's okay, why wouldn't it be okay? If that's someone you trust, if that's someone that you know, if that's someone who is, pregnancy is very much viewed as medical, and if that's a medical professional, then why wouldn't you do that? So it just shows you how much work we have to go. And now we think of that individual who is an educated white woman who has a very good job and who has had the same doctor for all of her life. We can think of how women from marginalized communities would they be given the same information? Were they given access to the same supports and services? Do they have the same capacity to seek out help or seek that information out? And we know that a lot of women want to stop drinking, but can't due to dependency or other circumstances and situations. So we know that during the pandemic, alcohol sales skyrocketed by 37% in the first 3-month lockdown. We know that our family and children's services across the province, as well as any agencies that support domestic violence and intimate partner violence, were saying that it's happening at extreme rates, and that we know it's happening and it's being underreported because of lack of people being able to leave their homes or be around those that support them. So we have to really think of those situations. If you're in a situation where if your partner wants you to drink and pregnancy is not an option, and even if you're pregnant, you should be drinking, and that might be what saves you in that home. There are a lot of factors that go into FASD and prenatally exposed pregnancies. So we used to say FASD is 100% preventable, and we don't say that anymore, because where there is alcohol, there's an opportunity for an FASD. We also love to let people know that the fastest growing rate of pregnancies exposed to alcohol is from women aged 35 with university educations. Because we know that alcohol is everywhere, alcohol is extremely accessible. We know that you can go on party buses with alcohol, you can get your pedicure done with champagne, you can get your hair done with champagne, you can have your booze delivered with your skip the dishes order. There are new apps that are called things like Drink Runner, where they bring drinks to your home. Karen and I are not anti-alcohol. What we are is pro-informed, like informed practices and informed decisions, and supports and access and equitability for women. We know that people will say, well, why don't doctors just ask? Why don't people just ask if people drank while they were pregnant? And I like to say to people, are you always honest with your doctor? If any of you were smokers back in the day or are, and the doctor says, do you smoke? And they say, how many? You're like, I don't know, like 3 a day. Is it really 3 a day? If your doctor asks, how many glasses of wine do you have a week? Will you say, yes, I drink every day. I drink a bottle of wine a day. And if that's what you need to get through your day, do you think a lot of people would be comfortable with that? You have to have relationships, you have to build relationships, and you have to know how to ask the questions. So we'll talk a bit about more of that today, but a woman's relationship with alcohol is a very, very unique thing. In a society where women manage households, they carry the mental load and a lot of the physical load and the actual load of homes, and they have their own careers. There's a lot of stress. So there's a lot of factors that can influence. Social media is crazy. Social media is full of ways on how to disguise your alcohol use and mommy wine culture. People are making an exorbitant amount of money as influencers steeped in wine culture. There are two that I personally like their content. I think it's hilarious. They're my demographic, but like they just got a line of alcohol and they're making very good money on that. There's nothing wrong with that. But if you are someone who spends a lot of time on social media and these are the women that you look to, right, to, to validate you and your experiences in your home, these women aren't causing you to drink, but it might be something that impacts your drinking. So we have to really look at those societal factors as well. Next slide, please, Karen. And so those living with FASD, there's a ton of stigma attached to that. We are strong advocates that if individuals do have an FASD, that they learn about their diagnosis as soon as they possibly can. You know, we always use the analogy of diabetes. If your child or the individual you support was diagnosed with diabetes, you'd want them to know what their body is doing, how their body is responding, how to use their body's signal, how to use the medication that they need or equipment that they need. FASD is no different. It is a lifelong disability. And so we need to include those living with FASD in the conversation as soon as we possibly can. Please know that treatment, especially treatment for mental health, can be effective when FASD is understood. For a very long time, we have heard, oh, no, we can't do that. We can't do cognitive behavioral therapy. We can't do talk therapy. People with FASD, their brains don't work that way. It's not true. We're going to talk a bit about that today. Strengths can be very easily overlooked because all we're looking at is all of the challenges: impulsivity, hyperactivity, confabulation, lack of sleep. And we're not channeling the energy of what their strengths really are. And there's a laundry list of strengths that individuals with FASD will tell you that they have, and there's a lot of similarities around them across the spectrum. But we have to make sure that we're in a strengths-based approach, because individuals with FASD can learn, but instead of it being cause and effect, it has to be strengths-based and meeting people where they're at. Individuals with FASD are often depicted as forever damaged or not able. My own clinician, when I was, and I adored him, he retired very early on me, but I said I wanted my son diagnosed, and he said, you can't unring the bell, you know. And I said, well, yeah, I know that. And a pediatrician legitimately said to me, what's the point of having him diagnosed though? Because it's not going to get you any services or anything. There's nothing for FASD. I think it's important that he was diagnosed so that he can know who he is, and I can help advocate for him and teach him to advocate for himself. And when coached and appropriate accommodations are made, there will definitely be success. A huge part of the role that Karen and I play in our FASD coordinator roles is coaching. We coach parents, caregivers, service providers, teachers. And it doesn't, once people learn it, it's not hard to make those accommodations, but understanding the FASD brain and the individual with an FASD is often the challenge. The accommodations aren't as challenging once we understand what FASD really is. And then we have to stamp out stigma on the experience, the lived experience of caregivers and parents. So we say caregivers in the FASD world because it takes a village to support those living with an FASD. We see anyone who supports a person living with FASD as a caregiver. We have birth parents, adoptive parents, and a large number of kinship placements that are primarily grandparents raising their grandchildren at a stage in life where they never thought that that would be what they were doing. And raising kids with an FASD is exceptionally challenging, can be extremely exhausting, and requires a high amount of cognitive and physical energy. So that's why we use the term caregivers, so that we are inclusive of everyone. So we're often seen as over-involved. You know, people will say helicopter parent. We are not helicopters, we are snowplows. Helicopter parents want to make sure nothing, you know, they know what their child can do. They just don't want their child to have to experience anything that's negative. Snowplow parents are clearing the path, knowing that some things might happen, but being as involved as possible to make sure that barriers are swept out of the way. And we know that our kids have challenges and where they might have obstacles, but we want to clear the path as much as possible. We are everywhere. You know, I've had 5 dentists because I cannot seem to find a dentist who understands what FASD is in terms of treatment. So people might see me come in and think, I don't know who this woman is, but I am not over involved. I'm an advocate. Sometimes when Karen and I are training summer staff students who are working with kids in summer camp settings, you know, you might get the parent, or we're talking to teachers and we say, you might get the parent that's like, hey, I don't care. Don't tell me about the problem. They're your problem from 8 till 5. See ya. I'll be here for pickup. And people are like, wow, like she doesn't care. No, they're tired. They're exhausted. They're at their wits' end. They might not have enough support. And that day at camp or school is actually the only form of respite that they're getting. And know that when they're taking that respite, they are probably stressed and just waiting for the phone to call half the time, the phone to ring rather, with a call that you have to do a pickup or something's gone wrong. With FASD, the way the brain works, oftentimes when we first hear from parents and caregivers on this journey, they will tell us immediately, they're so manipulative. And we go into in-depth in our other trainings on how manipulation takes a lot more work than most persons with FASD's brain can do. And so we will let a lot of things go. You might be at family functions or at events or school. One time my son, they had to do an evacuation. We got to the school, found him running through the school. And the first thing I did was put him on my lap and squeezed him. And I think the principal literally thought that I was rewarding him for behavior. And I said, look at his face. He's totally dysregulated and nobody needs to talk right now. And he needs his mother. So people think that we're just like letting them get away with it. We know our kids better than anybody. And our job is to create those supports and scaffolding. And for those of you that are here in parent support tonight, I know I'm preaching to the choir. Overprotective, absolutely. My friends are finally used to it. I can be sitting outside talking to my neighbors and friends. The kids are playing in the middle of the court and I'm listening to every word that's happening. And they're like, you got to let them play. I'm like, I am letting them play, but I'm also got an ear to it because I know a tone of voice change means that this whole playing situation can go south and it can go south fast. And again, the putting up with bad behavior. You know, our kids don't have a filter. Our kids don't know how to manage the tone of their voice. And will say things that are just, you know, probably considered not appropriate socially. But we have ways of communicating that. And we're not going to, you know, if your parents would say to you in the different generation, oh, I would take them out of the restaurant and that's it, they're going home. It doesn't matter. A kid with FASD wouldn't learn that. So it's our job to respond in the moment and know our child. And it's not always easy. Sometimes it's social detective work. Excellent. And so we did just to recap on stigma. Women are drinking more than ever. It's socially acceptable. It's absolutely everywhere. Binge drinking increases the risk. Binge drinking is 4 or more drinks in one sitting. So let's just all of us reflect on, for those of us that do have alcohol in our lives, if you go to a wedding, will you drink more than 4 drinks in the course of an entire day? We talk a lot about binge drinking when we're speaking with university students and high school students. Women over the age of 35 are the fastest growing group of demographic with an alcohol exposed pregnancy. FASD does not discriminate. This is not a status thing. This is not a demographic, a socioeconomic only. This is actually all of society. And again, 61% of pregnancies are unplanned, and we can access alcohol just about anywhere now.
All right, is this me, Michelle? Okay, so what does FASD look like? When I was talking to Andrea about doing this webinar with CMHO and Parents for Children's Mental Health, what I really wanted to get across was hoping that there would be one caregiver in our session tonight that has been going through the mental health journey with their family and hasn't considered FASD as an option. We wanted people to start thinking critically about, what supports and services that they access and what kind of supports and services and the quality and the appropriateness of those services that are provided. Because I think we continue when kids struggle in mental health settings, and because mental health interventions work for kids with mental health issues, right? They can be really effective. But when we put FASD into the works, it really doesn't work as well as we hope, and we really need to accommodate. So I was really hoping that there would be that one person here tonight that might think differently about how to support their child, and maybe a clinician in the audience too that might think differently about how they provide their mental health treatment within their organization. So FASD is everywhere in our communities, right? It's in our programs. If you work in a children's mental health organization and it's part of your policy to potentially not bring in kids with an FASD into programming because of some of the brain differences, let me tell you, there are already kids with FASD in your programs, right? Regardless of or not of whether it's an inclusion or exclusion criteria for treatment, we are treating these kids anyways. They're just being missed, and they're being misdiagnosed. And I'm going to go into what that might look like. Because it's really difficult sometimes to see because of the different way it presents itself. Once you've met one individual with an FASD, you've met one individual with an FASD, and they all look very different within treatment settings, home, community, school. And I think Michelle, highlighted the individuals with FASD are known for having several strengths and having a strengths-based perspective for identifying what they're good at and using the people around them to find what they're good at, using previous psychological assessments to read through, see what they're good at. There's lots of opportunity to identify what those strengths are for kids with FASD, and they have many, many strengths, and we need to really build on those. And then we're going to go into like, what does that look like? And we talked about challenges with learning and memory and attention, language, social skills, etc. So what I thought I'd do tonight is, and this is a bit different than what Michelle and I usually do, and I'm going to sort of paint a picture for you, because these are the areas that are often troublesome for kids with FASD. And I'm not going to go into each one of them individually right now, but what I'm going to do is I'm going to paint a bit of a picture for you about, what this might look like in a treatment setting. And I'm going to talk about a girl named Jenny, and she's 14 years old. She lives at home with her mom and her two younger siblings. So Jenny's mom is a single mom. And Jenny's mom is also a teacher. So she's an educator, and she's a special education resource teacher in a school. So Jenny's mom has a pretty good understanding of the system that supports children with mental health struggles. But Jenny, really struggled. And at an early age of 4, she was identified by her daycare. She was displaying aggressive behaviors with her peers, and she had poor social skills. So the daycare said to mom, she can't come back until she sees a pediatrician. Like this child is really struggling in our daycare environment, and she really needs to go see a pediatrician. So off Jenny went with her mom to a pediatrician, and that pediatrician diagnosed Jenny with ADHD. Usually the first diagnosis that Michelle and I will see that has been placed upon a child. And Jenny was prescribed stimulant medication. And really, mom didn't see a whole lot of difference when it came to Jenny's behavior once she started that stimulant medication, but they continued on because the doctor felt that was the correct diagnosis. So let's just keep on going on because doctors know what they're talking about. And then through the years, Jenny struggled at school, and peer relationships just became increasingly difficult. Report cards talked about difficulty with transitions and not responding to consequences, like both logical and natural. She just didn't seem to link cause and effect. She was unorganized, and she often lost her belongings. And the teachers would talk about her seeming to be much younger than peers her same age. So Jenny increasingly was feeling isolated and anxious, because I can imagine when you go to school every day and peer relationships are challenging and the work is challenging, that things aren't going well for her and she's not feeling that great about herself. So finally, in a grade 4, they thought, well, let's do a psychological assessment. Let's see what's going on with Jenny. Why is she struggling? And through that assessment, she was diagnosed with learning disabilities, multiple learning disabilities, and also diagnosed with anxiety and disruptive mood dysregulation disorder, so a mood disorder. And then meds were prescribed. And in addition, in that psychological assessment, mom was told, because she was sort of a fussy baby and a spirited child, that attachment between mom and her may be strained. And then mom was asked to take parenting classes to strengthen their attachment. So you can see where I'm going with this. We get services and supports, we get diagnosis upon diagnosis. And it continues on for Jenny, right? When she got into trouble, she had a difficult time taking on the perspective of others and was pretty argumentative with people. In school, she would surprise educators, but also frustrate her teachers, because she would learn new skills quickly and then forget them the next day. So her performance in school was really inconsistent. They signed her up for counseling, but traditional counseling didn't seem to work. And she got lost in the conversation, as reported by the therapist. And she didn't seem to be processing the information despite, the therapist trying to use less language. It just didn't seem to work. and she wasn't able to generalize the skills. So Jenny's mom got more and more and more tired and really didn't feel that they were getting anywhere despite many supports and services being tried. The diagnosis continued to pile up and interventions were less and less successful. So recently Jenny was hospitalized for suicidal ideation, and she happened upon a psychiatrist that was FASD informed. At the same time, Jenny's mom, in her job as a special education resource teacher, was part of an FASD training at her work. And the guest speaker spoke about FASD, and the more they were describing Jenny, or describing FASD, they were describing Jenny. And mom was really, having a bit of an aha moment, because Jenny was a surprise pregnancy. So it was an unplanned pregnancy, and her mom was going to teachers college during that time. And she remembers going out into the university bar scene on a regular basis. So she quit as soon as she found out she was pregnant, which was about 8 weeks. So she had an 8-week period where her pregnancy was exposed to alcohol. And that was sort of her light bulb moment. And as the speaker continued to talk about accumulating diagnosis and interventions not being effective, Jenny's mom was like, okay, I need someone to talk to about this. And she really didn't know where to turn. And she really did wonder, why didn't anybody over all these years of struggles not ask her about the prenatal period? And why didn't they ask about prenatal alcohol exposure? So fast forward a few days, at the case conference for discharge from the hospital, the psychiatrist asked to speak to mom alone. And in a really relational, non-judgmental way, the psychiatrist asked mom about Jenny's prenatal history. So relationship and confident and competent questioning led Jenny's mom to disclosing what her fears were, and was able to disclose to the psychiatrist that yes, she had drank during the first period of her pregnancy. And then that really did start FASD informed care for mom and daughter, and then started assessment through an FASD assessment clinic, and interventions were tailored to address the brain-based nature of FASD. So rather than taking a behavioral approach with Jenny, people started to look at her behavior through a brain-based lens, seeing that this is an organic brain injury caused by prenatal alcohol exposure, and that switched the approach that people were taking with her. And throughout the assessment process, there was support for mom and for Jenny. And after diagnosis was given, the clinic coordinator really did spend a lot of time with Jenny talking about what her FASD means for her. So that's what FASD can look like. And I can spend lots of time going over, what impulsivity looks like, and what literal thinking looks like, and what difficulty with transition looks like. But this is where we're not necessarily getting it right for kids. So if we don't get it right, then, there's lots of difficulties that can happen. And these adverse outcomes, it's a situation that can occur when the environment is a poor fit with meeting the needs and the developmental age of the individual with FASD. So individuals with FASD are at risk for, adverse outcomes, right? Mental health disorders, homelessness, alcohol and drug addiction. You can read the list. I don't need to read it to you. And I don't like to spend a lot of time on the negative aspects of that. But when we don't get diagnosis right, and if Jenny wasn't supported properly through the last part of her teen years, things probably would have not gone so well for her. But now that they have a better understanding of her brain-based disability, they can support in a more appropriate way. So, sorry, I just need to move you guys out of the way on my screen. So we don't get it right sometimes. And that's because assessment of FASD it's really tricky stuff, right? We don't have capacity in Ontario to be assessing all the kids we need to. Assessment of FASD involves a multidisciplinary team. So we need a pediatrician, a psychologist, a speech and language pathologist, and an occupational therapist. And they look at many different areas of brain function, like motor skills, like cognition, like language, executive functioning, memory, academic achievement, affect regulation. So it's really a time-intensive assessment. And it's costly if families don't have a clinic accessible to them in their community. It can cost upwards of $5,000 to get a private assessment. So it's not equitable, and there's no way we can keep up with demand in the resources that we currently have. And I can go in at the end of the presentation. I have some links as to, what community you're living in, where might you find the resources for assessment in your community. But sometimes we don't get it right because of this. And there's other reasons why misdiagnosis happens, right? So what are some factors that play into misdiagnosis? So in order to receive a diagnosis of FASD, you have to have prenatal alcohol exposure confirmation. So first of all, you have to have that confirmation, but backing up even a little bit more, you have to have somebody in your life that's even questioning whether or not prenatal alcohol exposure has been happening for you and your child. So it's not available to all. FASD is not in the DSM, so the Diagnostic and Statistical Manual of Psychiatric Disorders, the Bible of psychologists and psychiatrists. It's in the back in an appendix for consideration, but right now it's not in there. So if you go to psychology or psychiatry, they look at your behaviors and they line them up with what it looks like the most. And, like our example of Jenny, it typically starts with an ADHD diagnosis and then maybe an ODD and then maybe an anxiety disorder. And they start to accumulate these diagnoses, and they're all a little bit of these things. But when you look at it through the FASD lens, it makes so much more sense to people when we look at that through that holistic view of FASD rather than different diagnosis, which it really is not. So there's really that lack of awareness within our mental health community about how are we even asking or screening for FASD. There is not an evidence-based screening tool for FASD. That's something we need to work on. So we need mental health practitioners to start asking and building their confidence in asking the question about prenatal alcohol exposure. I've had many, many conversations with all sorts of families about prenatal alcohol exposure. And the more you do it, the easier it gets, right? It's a matter of fact conversation you do through relationship and a non-judgmental approach. And the more you do it, the easier it comes to you and the more confident you are in doing it. And then we have to think too that 90% of individuals with FASD have co-occurring mental health concerns. We know that individuals with an FASD have higher cortisol baseline levels, and that there's persistent changes to the normal stress pathway and brain function, and this can lead to the development of mental health disorders. So there's something in your body called your HPA axis, which is your hypothalamus, your pituitary gland, and your adrenal cortex. And that's how cortisol is regulated through your body. And we know that pathway is biologically different in individuals with FASD. So they're more stressed out, which then can lead to many more mental health concerns. In addition to that, children and youth with FASD or prenatal alcohol exposure experience higher rates for adverse childhood experiences, so ACEs. And they can include like disruption in their caregiver situation and exposure to substance use and mental health issues in their home. So individuals with FASD or prenatal alcohol exposure experience brain-based and environmental changes throughout their lives. So their lives often aren't consistent and they're often disrupted. So that also can play into mental health issues. So they're a very vulnerable group, and they can also experience higher rates of abuse and neglect and traumatic experiences. So you can see how, these things play upon each other and just increase their chances of also having mental health concerns. So sometimes kids will present to children's mental health organizations having significant mental health issues because of all these things, these compounding brain-based vulnerabilities, if you would call them that. and they're not, and clinicians and families aren't looking deeper into prenatal alcohol exposure and the possibility of that, because the interventions are going to be different. Mental health treatment can absolutely be appropriate and doable and successful for individuals with FASD, but it has to be flexible, it has to be creative, and we have to make sure that we're making it work for them and not just trying to put the round peg into the square hole, because it's not going to be successful for them. So Michelle, I want you to jump into some of these next slides about like what works for people, right? So we know that FASD education, that is of primary importance across all sectors, that people need to understand what FASD is all about. People need to have an FASD informed practice and an awareness that FASD is a reality for some people. And that's, they need to have a strong theoretical and practical understanding like of the characteristics, but also the barriers and the needs of those affected by FASD. And they need to be willing to be part of staff or of families that support individuals with FASD. They need to be participating in ongoing FASD education and training, because things change quite quickly. You know, children's mental health organizations and families also need to think, you know, differently about how they support individuals with FASD and how they provide service, or how they provide a home environment that's conducive to FASD. And just think differently and use reflective practice. So thinking on what you're doing and is it working, and then being willing to change things. So we need to have consistent FASD education across all sectors. This is not something that just is needed in children's mental health organizations. This is across justice, education, public health, law enforcement, the justice system. There's just such a lack of really consistent, good information out there. We also know, and evidence shows us, that early diagnosis is important. So the earlier we start asking about prenatal alcohol exposure, the better the outcomes are going to be. It's tricky to diagnose kids before the age of 6 based on some of the tests that are used in the diagnostic process. But there is a designation now. So the diagnostic criteria, or the diagnostic terms now, are FASD, or FASD with the facial features, but really the facial features don't tell us anything about how the brain functions. It just tells us there was prenatal alcohol exposure. So those are the two diagnoses that can be given. But then there's also a designation that can be provided, and that's at risk of prenatal alcohol exposure and neurodevelopmental disability, or something like that. I think that's a term. So even if we wonder about FASD, but we feel the child might be too young for the multidisciplinary assessment, we can at least give a designation. So it's a bit of a marker or a flag that will follow that child moving forward. So people can start wondering about, is this a brain-based disability that this child is living with?
And the education piece around that as well. So the programs that myself and Karen and the other FASD coordinators across the province, the provincial funded ones, we support 0 to 18 and 21 if still in school. And I've had conversations with parents of kids who have 9-month-olds and know that their child was prenatally exposed, and they're starting to get education now. They have no idea. You will not have any idea if there's any non-physical indicators. But we're supporting, you know, I have a 9-month-old, a 1-year-old, and a 3-year-old, but that's so important that having this education and this understanding has a lot of impacts just in supporting the child, but also in decreasing the, you know, the constant going to service providers and looking for clinicians and looking for assessment and sitting on waiting lists, and, you know, everybody kind of banging their heads against a wall. And the cost that comes along with that is a huge part of education as well.
And one thing I want to mention too about life course theory before I forget it, because that often happens, is something comes into my head and then I forget it very quickly, is thinking about how this is a multi-generational disability, right? So even if you are working or supporting a child with an FASD, you also may be supporting a parent with an FASD. And how do you coach that parent in a way that's FASD informed too. FASD does not go anywhere. This is something that will affect them the rest of their life. And in life course theory, we look at, what are these major transitions in life? So from, you could think of from grade 8 to grade 9, so entering into high school. You could think about entering into adulthood. You could think about entering into a relationship and having your own child. Like all these transitions are really important in an individual's life. And they're so integral in this, if we don't get it right, it can really fall off the rails for individuals with FASD too. So we have to think about, how do we think forward and think ahead into how do we support them better as we move, in that life trajectory, and being planful about that, because we need to start thinking, like in the work Michelle and I do, we support up to the age of 18. So we start thinking about transition to adulthood at 14. Right? How do we start planning for that? So it's really important to be thinking ahead, and not just using that snowplow analogy for parenting, but using it for planning for future needs. We have to address stigma. Michelle did a really good job of talking about stigma and how we don't get the credit, the coverage that other diagnosis or situations get. There was recently a Saturday Night Live skit that depicted an individual with an FASD in a very stigmatizing and horrible way. And the FASD community was outraged. And we were all tweeting and messaging each other, but we were just tweeting and messaging each other, right? Like it really never went, the anger didn't go beyond our community, our FASD community. And why didn't it, right? Like why was that not recognized in a larger context? In Waterloo Region, we got a little bit of a radio coverage on it, but from just that, I don't recognize anything else that's really happened outside the FASD community. So I attribute that to stigma. Like people aren't really recognizing that this is something that, number one, happens to everybody because of the lack of awareness, but there's also that stigma attached to FASD. And then addressing grief and loss is really important when we support families and when we support individuals with FASD, because they can go through their own grief and loss journey after diagnosis. We support parents through grief and loss through the FASD diagnostic process, but also in times where it just really creeps up on them and they don't understand why they're upset or why they're sad, or they see their child struggling and it's just another experience where they're feeling grief and loss around their child's diagnosis.
And not recognizing those compounding events, it becomes your norm. The school calling every day is your norm. Having to I call it Groundhog Day. Like you've got to be so consistent every day with the same structure and routine, and that's your norm. So you forget that that's a little exhausting. I had a moment in the fall with my best friend, and her daughter lives with ASD, and we were both like, I wonder what it's like to just send your kid to school. And for me and a lot of the parents of kids with FASD, it's like, I wonder what it's like for the principal to not know your kid's name. Or what's it like to just be able to let your child go to someone's house, or have someone come over to your house, or go to a family function, or really dread holidays because of dysregulation. But it becomes your norm. And then you can't figure out why you kind of go down in the dumps a bit, or you're struggling with things, and you realize it's like, oh, I do this every day, and this is exhausting. And this isn't typical. This is normal for us, but not typical. And so where do we help caregivers do that, addressing that grief and loss in their everyday lives? Because there's something about parents and caregivers of kids with exceptionalities and special needs, man. We just plow along and it's like, it's fine, it's fine, it's fine. This is our life. But it's really important to lift the veil off of that, because it can be exceptionally detrimental.
And also when I think about grief and loss, I think about grandparents that are parenting their grandchildren, and they've had many experiences of grief and loss because often they have perhaps lost their own child. because that parent is not able to parent. So where are they? We've had parents with, that have lost their children to addiction and are no longer with us. So they're grieving their own child, and they're grieving their retirement, right? They're grieving, the time that they were supposed to have to themselves and do special things and even retirement income, right? They've lost supporting their child. So making sure that we look at that generational nature of grief and loss also. We have wonderful caregiver support groups across the province now. We're lucky to have them, because addressing that caregiver stress and making sure that we have a safe place for caregivers to go that understands the unique nuances of FASD is really important. But it's also important too to think about respite and relief. Respite is, planned and organized, and relief is who do you call when you need a break because you just can't do this for 1 second longer. And how do you build that circle of support for yourself and for your family? And same goes for, I worked in residential treatment for part of my career in a children's mental health organization, and thinking about how you just need respite and relief and use your coworkers to do that, right? Like everybody needs a break sometimes. So it's really important to make sure that people have that break. And then, like Michelle talked about too at the beginning of the presentation, how it's super important to be teaching children and youth about FASD. There's parents I have worked with over the years that really, really struggle with talking to their child about their FASD. And we have some really good, frank conversations about what is that about? Why is this something you just aren't willing to go there with them yet? Is it stigma? Is it fear? Is it shame and blame? Like, what is this that we're not talking about it? And we have to be patient, and we have to be respectful, and we have to have lots of conversations about the benefits of talking to children about their FASD, and having kids that have FASD meet each other, right? It's really isolating for individuals with FASD, and we really want them to meet each other and learn from each other and feel like they're not alone. So these are really high level what works options, right? And it's a combination of all of these things together that can be really supportive of families. And to talk about FASD in an hour and a bit is challenging, right? And I hope we gave you a really good overview. And I'm hoping that that we can have a little bit of a conversation if there's some questions too. I just wanted to highlight for you some provincial resources, because it's always great. The worst thing actually is to come to a presentation and talk about all these things and then not to know where to go for help. So this is what you would look into. So we really like CanFASD Research Network. That's where we get all our research on our evidence-based information about FASD. And then there's an FASD provincial website, and it has a roster of all the FASD workers across the province. So the Michelle and I of the FASD world are listed on that website, and you can just go in and see what region you're from, and then find your worker that way, and they can help you navigate the FASD world. And then on FASD1, there's a list of diagnostic clinics. We've had an infusion of Ministry of Health funding recently, which is wonderful. However, I don't know that website is totally up to date on the clinics, but your FASD worker would probably know where assessment might be able to happen for you. So those would be the top 3 things that I would check out. And then this is just mine and Michelle's information. We have a website in Waterloo Region, and we have a bit of a social media presence. I run our Twitter account, and Michelle is our Instagrammer. And then those are our email addresses if anybody wanted to connect or had questions from tonight. Stop sharing my screen and just see if we have any questions or comments or thoughts.